Bienvenidos. It's so good to see you all again as we kick off a new season of the show. Now, I'm telling you, I was out sick for a little bit, and we'll talk a little bit about why I was out sick. But I have here the gentleman who is the major force in why I have recuperated so well and that I'm back working so quickly. So please join me in welcoming Dr. Jiquan Zhao.
Hi, everyone.
How are you, Dr. Zhao?
I'm pretty good.
And thank you so much for taking time out of your busy schedule to come and share a little bit about what you do as an OB/GYN.
Well, thank you for inviting.
Absolutely. So tell me, what inspired you? First of all, you're from China. You were trained in China.
Right.
And what inspired you to become an OB/GYN?
Wow, I don't know if it's appropriate for me to talk about that. I always wanted to be an OB/GYN since medical school. However, I couldn't get into an OB/GYN residency program in China.
Why?
It's too competitive.
Really competitive.
Very competitive. And most graduates would need some social connection with the hospitals to get into
So how
the
did you
program.
eventually get in?
Well, only in the United States.
Okay, here. Okay.
Yes.
All right.
I was trained as a surgeon back in China.
Okay.
Yeah.
So you've done all sorts of surgeries.
Different things.
Okay. Like
Different
what?
things.
What have you
General
done?
surgery.
Okay.
Gallbladder removal. Rectal cancer.
Okay.
Colon cancer.
Oh, wow.
With something like a subspecialty in breast cancer treatment.
Oh, wow. Okay. All right. So let's talk a little bit about preventive care, because that's what all women need to do.
Sure.
And if there's anything that a male can help in that woman's life to help make that happen. So let's talk about some preventive care, PAP, pelvic, breast examinations, all those things. Tell women what they need to get done on an annual basis.
On an annual basis, all women should have the basic, as you mentioned, the PAP, pelvic, and breast exam. Of course, what really is required for a single individual would be dependent on her age. For younger women, there's no recommendation for pap smear until they turn 21.
Okay.
And the mammogram is only recommended for women at the age of 40 and after. There are exceptions, women who have strong family history for breast cancer. Some women may have multiple surgeries in the breast, different biopsies, and they probably should have earlier mammogram. Okay. And pap smear, as I said, is the recommendation for pap smears have changed constantly.
Okay.
And recently the recommendation is starting pap smear at the age of 21, maybe every 2 to 3 years afterwards, unless somebody has a history of abnormal pap smears.
Okay. So I know that a lot of women sometimes don't have access to medical care, insurance, etc. So how can a woman know, what are some signals that something might not be right and that you need to get to the doctor?
In the old days when women didn't have access to regular GYN care, the most common symptoms we looked for in someone with cervical cancer was bleeding vaginally, abnormally, sometimes bleeding after sex. Okay. Nowadays, most women do have access, especially in the United States and many other developed countries. Most women do have access to regular checkups. Thus, the incidence of cervical cancer remains much lower than those found in developing countries.
Okay.
Yeah.
So with breast cancer and getting the self-breast examination and then mammographies, tell women what they should look for there.
Breast self-exam is always recommended by American College of OB/GYN. There's absolutely, unfortunately, no evidence that self-breast exam makes a difference in terms of prognosis if somebody is diagnosed with breast cancer. So American Task Force actually stopped recommending that.
Oh, wow.
But we continue to recommend
it.
And ACOG hasn't changed that recommendation. Things to look for is, first, women should know what is the right way to do a self-exam. You really can't squeeze against the breast tissue. Rather, you should palpate from above, just with the fingertip, feel for anything abnormal. And most women are good at doing that. And the recommendation for mammogram, of course, whenever she turns 40, and we start offering that every 1 to 2 years until she turns 50, then every year after.
Okay. So I've heard, I don't know if this is true, that if you feel something on one side and you don't feel it on the other side, that you should run to the
That's
doctor.
probably something like a trick, yes, absolutely.
Okay.
I have had 2 women in the past 4 years who arrived themselves because of concern for different
Feel on one side
feeling
than the other.
on the breasts, and one actually had cancer.
No.
And the other something benign.
Okay. So, and then there's another myth I heard. I'm not sure if this is true, but I also heard if you feel like a small lump and you can move it around, that you might have a little cyst or a little tumor there, but it's usually not cancerous. That cancer is usually attached to your skin. Is that true?
It can be true in certain cases. If a little mass is movable with good clear margin, usually these are benign tumor. One benign tumor in the breast is something called fibroadenoma, just something benign. It does not change or increase the risk for cancer. Okay. Cancer, usually breast cancer does not involve the skin unless it's relatively late stage. When skin is involved, we are concerned that there might be metastases. The cancer may have gone somewhere else, the lymph nodes in the axilla, for example, in the armpits.
So let's talk about the fun part now of delivering babies, bringing new life into the world. That has got to be.
That's what we do too.
The most awesome.
As OB/GYNs.
Yeah, the most awesome thing. Tell me about your first delivery, what that was like for you.
First delivery, since my practice or since my residency training?
Your very first one.
Very first one.
You were the catcher.
Let's just talk about the first delivery that I had in my practice. Yes. I was on call that day. Okay. It is August 22nd, 2008.
Oh, wow, okay.
I had my first call that day since I started practice in a hospital in Wisconsin.
But you've been a doctor for a long time.
Yes, 4 years of training before that.
Okay.
It's a patient, actually, of my partner's who arrived in labor, full term, no complications.
Okay.
Yeah, there's a lot to talk about that. Yeah,
Did
it's amazing. Almost, because the family shows so much appreciation after delivery. Actually, I had pictures
I would too.
With the little baby, and actually some more pictures a year after that.
Oh, that's awesome. I think that is so awesome.
Yeah, everything went well. There's no complications. Mom was happy, baby was happy, and I will never forget. August 22nd, 2008.
Wow. I was with my friend when she had her baby, and she had complications. He just wouldn't come out, so they decided they were going to do a C-section. And they had like a little curtain over her so she couldn't see, and when they cut her, I thought I was fine. I felt okay. And the doctor flipped up this thing on her belly, and I go, "What's that?" And he said, "Oh, that's a fibroid." And I was like, "Cut it out, because it's pretty good size." And he said, "No, I'm going to put it back in because it'll go down after I take the baby out." And then the next thing I heard was, "Catch her, catch her." And I said, "Catch who?" Well, it was me. So all I know is when I woke up, I was in the bed next to her. Oh yeah, I fainted. Oh yeah, I was not.
That's not uncommon.
And
for women.
She's looking at me like, "Thanks for being my support." And I'm like, "I'm so sorry." Faint.
Well, that's quite some experience.
But I didn't even know I was going to faint, so that was kind of nerve-wracking for me. So have you had a multiple birth yet?
I had quite a few twin deliveries, yes. And most of them actually delivered vaginally.
Okay.
Both twins.
Wow. Okay.
And some, of course, delivered by cesarean section. Yes.
And what's been some maybe challenges for you in delivering babies?
I think for any obstetrician, The most challenging would be some unexpected results, something that you certainly didn't anticipate. Shoulder dystocia is one of many, of course.
And what is that? Shoulder?
Shoulders. So the baby's head is born, but the shoulders get stuck.
Wow. Ouch. That's all I can say. Ouch.
Fortunately, I haven't had any
that's good.
bad experience with that. Everybody would have had a few cases of shoulder dystocia, but I did, but I, all
you were
the
able
cases,
to,
we're able to really resolve that with no complications.
Yeah, a little butter.
Different manipulations you can do, and of course, mom, whatever the mom does makes a huge difference too.
Okay, excellent. And I also wanted to ask you about breech babies.
Breech babies.
Yeah.
Since the 1998 study in Canada, it's a multi-center study. Breech extraction is no longer recommended. So if somebody is found to be in breech presentation, usually the recommendation is either go for elective cesarean section at around 39 weeks, or we can try to so-called external version, try to turn the baby around. So she can have a vaginal delivery.
Okay, very good. Very good. So breech, for those that don't know, breech babies when the legs are first.
Right.
Instead of head down, legs come first.
That's right.
Yay, okay. Did you deliver your own son?
I wasn't allowed to at that time.
Oh, they don't allow you.
I was doing research in the lab at that time. Really, just a couple months before I started my residency training.
Okay. He came just a little too soon.
Yeah. He came, yes. He was delivered in New York, and I did my training in Detroit.
Okay, excellent. All right, when we come back, we are going to share a crazy story with you, and I'll share a little bit about my own robotic surgery, the newest thing, and Dr. Shikwan Zhao is the best at it, so stay with us. We'll be right back. Welcome back to the show, Bienvenidos, and we are here talking with Dr. Shikwan Zhao, who is at the University of Connecticut Health Center, and he is an amazing OBGYN and tops in his field in robotic surgery. That's one of the reasons why I had him come. I went to Dr. Zhao saying, oh my God, I'm using the bathroom like every 2 minutes. And not that often, but more often than I should. And come to find out, I did have a fibroid, which he removed for me robotically. So tell everybody a little bit about robotic surgery. But before you even do that, I gotta thank your team. I gotta thank the entire team.
You are so welcome.
That you work with. You're amazing, and your entire team they are incredible. So I want to name them as you see them here. You'll see pictures of Irene, Carol, Tyshawn, Nancy, Lorna, and Cindy. And along with them, there were nurses who prepped me, the anesthesiologist, I love you, no pain. I felt no pain when I was not awake during surgery. I think that's one of the most important doctors there can be, an anesthesiologist, so you don't feel anything. And then, of course, you, who did the bulk of the
I think we did what we are supposed to do.
Yeah, but
you are special,
I think everybody does what they're supposed to do on a daily basis, but there are certain people that do it with genuine care and love for what they do. And I don't care whether it's medicine or education or fixing a car, there comes a passion with that.
Sure.
And so
that passion makes a difference.
My hat's off to all of you for having that passion. Really appreciate it, and my family really appreciates it.
Thank you for the compliment.
Yeah, absolutely. So let's first of all talk about fibroid. What is a fibroid?
A fibroid is a type of benign tumor that can be found in the uterus, the womb. Of course, for many women, the most women with fibroids don't have any symptoms, but the most common symptoms for women with fibroids are two. One is abnormally heavy bleeding or prolonged bleeding. Two, severe pain or dysmenorrhea, called the cramping pain associated with menstrual cycles.
Okay. So if a woman goes to the OBGYN, she gets her pap and pelvic, and they tell her, you have some fibroids and they're the size of a pinhead, and you have several. Should they worry?
Mostly no.
Okay.
It depends on whether she has any concern. She's bothered because of fibroids.
Okay. What if she is still able to bear children and she wants to have children? Do you suggest removing them before having children or no?
It depends on the location of the fibroids. Okay. If the fibroids can grow on the surface of the uterus, it can grow in the muscle layers. It can grow really deeper in the lining, very close to the lining. Those fibroids close to the lining may be causing difficulty getting pregnant or increased risk for miscarriage for some women. So it depends. If somebody does not have any history of any problem getting pregnant, there's no need to do anything. But for those who do have problem achieving a pregnancy, removal of the fibroids may be reasonable, and it's actually commonly done something called myomectomy.
Okay. So I understand it's very common that many women have fibroids. How come, and what causes them?
I don't think we understand exactly what's causing the fibroids, but the understanding is there's a single type of cell originating from the muscles, which continues to duplicate, and eventually it's getting bigger, like a mass growing bigger, known as fibroids. Yes.
All right. So let's now discuss your most challenging surgery. I know you had a patient that you did a robotic surgery on, and it was quite the challenge. And we're going to put up some pictures here for you to tell us about. So the first picture that people will see, can you describe that?
Absolutely. The first picture actually shows some scarring tissue between the anterior abdominal wall and the omentum, part of the fatty tissue connect to the bowel. This specific patient has a history of surgery for removal of the fibroids, and we believe the scarring tissue was secondary to the surgery that she had.
Yes, she did have a bikini cut surgery. Yeah, she shared that with me.
Okay.
Okay.
And before we could do anything, we had to really remove the scarring tissue to actually see where the uterus was, where the fibroids were.
Okay. So the next picture we're going to see, can you describe that? And that is a pretty good size fibroid.
Yeah, the next picture was taken after the scarring tissue was taken away. Apparently, what you can see here is a very tall uterus. I have to say tall. I don't know. It's kind of elongated, really. At the very top of the picture, you see that's actually the very start of the uterus. And you see a little bump to the right, and that's a fibroid. And further up, there's a bigger lump here with blood vessels on the surface.
Wow.
This is a bigger fibroid. And the vessels are there because the fibroid tumors really needed blood to grow, to keep growing. Yes.
And it's the biggest you've seen, right? The biggest you've ever
quite big.
seen. Yes.
Overall, the uterus and the fibroids together really made that patient look like she was 5 to 6 months pregnant.
Yeah, exactly. And then the final picture, talk a little bit about that, and then I want you to really tell us about how difficult. I know that surgery was very difficult for you.
The last picture is not much different from pictures from other women who had the same procedure. Basically, what we see is the top of the vagina that's closed, the vaginal cuff, we call vaginal cuff, that was closed, and there was no bleeding. The bladder looked fine. Everything just looked great after surgery.
After surgery, perfect. Perfect. So tell folks how long, the typical surgery I know is about an hour and a half, but this surgery took you a little over 6 hours, I believe?
It's close to 5 hours.
5 hours. And how long cutting this up, getting it out through those six little incisions? We're going to show the incisions right now. Here's a picture of one of the incisions there. Folks are looking at that picture, and you see how tiny that incision is. How did you get this big thing out of those little tiny
Yes,
holes?
the whole case lasted longer, which was completely expected because of the bulkiness in the uterus and fibroids, and her history of surgery in the past. We really spent time, almost 45 minutes, just to get the scarring down, to see the uterus. And after that, of course, we have to do something called myomectomy to remove the top of the fibroid at the very top of the uterus, so that we could see better lower in the uterus where the other fibroids were identified. And we did actually 2 fibroids. We removed 2 fibroids before we could actually start doing the hysterectomy. And of course, because of the scarring tissue, there was significant difficulty identifying the normal anatomy. And there was scarring formation between the back of the uterus and the anterior wall of the bowel. So we were able to take that down, and then we could see normal anatomy, and then we could get the uterine vessels, really secure the vessels, and they keep moving on. And the key is how to really get the big fibroid uterus out. That's a very good question. You probably would think nothing is going to come out of the very small incision. We actually have to use an instrument called uterine morcellator. Basically an instrument that will grab on the big fibroid uterus, and a little piece of tissue will be taken out.
Is that the claws that you see here in this picture?
Say it again, I'm sorry.
Is that part of the
instrument?
No,
it's different.
No, okay, it's a different instrument.
I don't have anything on these pictures, but it's called uterine morcellator.
Okay.
So with the morcellator, small piece of tissue were taken out. Of course, that morcellation itself was quite time consuming, but I think it's all worth of it. Eventually, patients with robotic assisted hysterectomy will do so much better because they don't have blood loss, significant blood loss, have major complications, and they recover faster. They usually stay in the hospital overnight and then they'll go home. And they usually recover pretty well. Within 2 weeks, a lot of women may return to normal activity, and some may go back to work if no heavy lifting is involved.
Right. I think I recouped pretty well. So let's talk about those incisions now. We're going to see some pictures of the incisions, and there are 6. The top one is, what's that one?
The top one is for the scope, the so-called endoscope, and this is the little window through which we can see where we are, what we're doing.
Okay, and then the other incisions are just
the other incisions are for the so-called robotic arms. We need to have the little arms to assist in surgery.
And we'll see a picture of the robot there.
Yes, and some of that incisions, the left lower quadrant was where we made the incision to put the morcellator through, so we could get the fibroid uterus out there. Yes.
So I looked first of all online about everything before I had the robotic surgery and tried to learn as much as I could, and seeing the robot and the doctor sitting working the control made me think, like, if your doctor is really good at video games, he's going to be pretty good at the surgery.
Yes.
A little eye-hand coordination movement.
There were some studies which showed that kids who are good gamers really function better than some physicians, some surgeons.
So the eye-hand coordination, that little
is
joke
very
wasn't
important.
a joke. It's very true.
It is very true.
Very true. Okay. And now we're going to show some post pictures of what the incisions look like, and that's at 5 weeks, and you almost can't even see 2 of them. They're basically almost gone.
Usually, yes, they feel really they heal really well by 5 weeks, and you may see a little discoloration. Other than that,
and what did you use to seal the incision? Because there's no stitches. It almost looks like super glue.
we did use super glue on top of the skin, but the skin.
You were joking.
I'm not joking. It is real.
That's real super glue?
Yes, it is something called derma. It is a glue that's that's used, safe used on human beings.
Oh wow. Yeah. Okay. It does, you guys. It looks
But
exactly like
before
it.
the
You can look at the incision. I'll put the picture back up so you can see that little.
Yes.
Over
Before the super
incision.
glue was applied, the skin incision would need to be closed with subcutaneous closure.
Okay.
So the stitch, the suture was buried under
Oh,
the
it's
skin.
buried under the
Yes.
skin.
Yes.
Is that for cosmetic reasons?
Absolutely.
Because you know we women are vain.
We do want to make all women look beautiful.
Okay.
If we can.
That is so awesome. So how many robotic surgeries have you done?
Now it's really about 100.
Yeah, about
Yes.
100.
Not many, but enough to say I'm really comfortable with the
Oh,
procedure.
absolutely. Absolutely.
Yes.
And so how would a woman know if she's a candidate for robotic surgery?
Let's put it this way. Any patient with big fibroids could be a good candidate for that. Certainly in the past, a lot of women had hysterectomy done with big incisions. Then some women have had hysterectomy done through the regular laparoscopy. These are stiff instruments, commonly used still for a lot of providers. Especially, I'm using those too for minor procedures such as tubal ligation, diagnostic laparoscopy, to look for reasons why women have pain in the pelvis. But with the robotic approach, we can really conquer bigger fibroid uterus.
So a woman, if her doctor tells her, you need to have fibroids removed, almost any woman can come to you to get robotic surgery then.
Yeah,
basically.
most women are.
Because you're not going to see
candidates.
anything as big as this anymore. So if you can get that out, you can get almost anything out.
Mostly. The exceptions are actually, I had a couple of women I have to really abort the procedure.
Okay.
Both had problem with their lungs. And when the robotic hysterectomy is done, the patient is put in head down, legs up position.
Yes.
And those women with lung problems may not tolerate that position, and they may have problem getting the oxygen.
Okay. No,
into
I
the
was
lungs.
good. I bet I'm fat, but I bend like Gumby. Anyway, we're going to wrap up the show, Dr. Zhao.
Absolutely.
It was so great to have you here. I thank
Absolutely.
you so much personally, and my friend who had her surgery, she thanks you too. And if you need robotic surgery, this is the man to see, Dr. Zhiguan Zhao, out of the University of Connecticut. And I want to thank you at home for watching. I want to thank my viewers over in the UK and in Ireland. And welcome, Jamaica. I understand you pick up the show. I'm so happy that you all are watching. And you will see more of Linnet Carty's show in our next taping. Thanks for watching. And remember, I love you more than I love cooked food.